All right, welcome everyone. Today, we're going to do a quick clinical refresher on acute otitis media. We'll be looking at this specifically through a pharmacist lens, using the latest Canadian guidelines to make sure we're all on the same page. Okay, so here's our game plan. We'll start with a quick look at the clinical picture of AOM. Then, we'll get into that really big question, to treat or to wait. After that, we'll talk about our first-line antibiotic choices, what to do when things don't go as planned, and we'll wrap it all up with the most important counseling points that we can give to caregivers. All right, first things first, let's get the clinical picture straight. We see these prescriptions all the time, right? So let's make sure we know exactly what constitutes a diagnosis and who the usual suspects are. So, here is the absolute key for diagnosis. It's not just about a red eardrum. To really be AOM, you need both fluid in the middle ear, that's the effusion, and signs of acute inflammation. The real giveaway is that bulging eardrum. That's the one that confirms it. Okay, so these are the big three we're going after with our antibiotics. But here's the thing, they are not all created equal. And this is really important. The chance that the infection will just clear up on its own is only about 20% for strep pneumo, but it jumps to 50% for H. flu and a whopping 75% for Moraxella. And that difference is exactly why our next topic is so critical. Okay, this next part is huge. It's probably one of the most important judgment calls in managing AOM, and it's where we as pharmacists can play a major role in antimicrobial stewardship. We're talking about watchful waiting. 60%. Just let that sink in for a second. A huge Cochrane review found that 60% of kids with AOM get better all on their own within 24 hours, without a single drop of antibiotics. That's an incredibly powerful number to have in your back pocket when you're talking to a worried parent. Now, of course, we can't just do this for every kid who walks in the door. There's a specific checklist from the Canadian Pediatric Society. The child has to be older than 6 months. The illness can't be severe. So we're talking a fever below 39 degrees and only mild pain. And, this is the big one, the parent or caregiver has to be able to tell if things are getting worse and be able to get back to a doctor easily if they need to. So, what about when watchful waiting isn't the right call and we do need an antibiotic? Well, the first choice is pretty clear, but the real debate is all about the dose. No surprise here, amoxicillin is still our champion. It works well, it's safe, and most kids don't mind the taste too much. And here's some good news. Thanks to the pneumococcal vaccines, we're seeing way less penicillin-resistant strep pneumo, which just makes amoxicillin an even stronger choice. So the big question is, standard dose or high dose? Well, the guidelines tell us to lean towards high dose if the child has risk factors for resistance. Things like being in daycare or if they've had antibiotics recently. But for a lower risk kid, standard dose amoxicillin is still a totally reasonable and very effective way to go. Okay, so that's plan A. But what about plan B? What do we do when amoxicillin doesn't cut it, or a patient says they have a penicillin allergy? This is where we really need to know our stuff. Let's break down those second-line options. This little table is a great cheat sheet. If amoxicillin failed, you're likely going to see a script for amoxicillin clavulanate. Your big counseling point there? Diarrhea. For sure. For a non-severe penicillin allergy, cefuroxime is a good option, but you have got to warn them about the taste. It's really better. Azithromycin, we're saving that for a true, serious type 1 allergy because resistance is becoming a real problem. Clindamycin is also in that category, but remember, it leaves some big gaps in coverage. It doesn't touch 2 of our 3 main bacteria. Okay, this is where we get to put on our detective hats. Anytime someone mentions a penicillin allergy, you have to dig a little deeper. Was it really hives and wheezing, or was it just a mild rash, or maybe some stomach upset? Taking a minute to clarify that history is huge, because it can be the difference between using our best drugs or having to turn to a less effective alternative. All right, let's bring this all home. This is where the rubber meets the road for us, turning all this clinical knowledge into simple, clear advice that helps caregivers, improves how well the medicine works, and gets better outcomes for these kids. This right here, this is the question we should be asking ourselves every single time we counsel a caregiver for an ear infection. What do they absolutely need to know to manage this thing well? Okay, first up, how long to treat? This is a really simple but critical point. For the little ones, anyone under 2 years old, we're still doing a full 10-day course. But for kids 2 and older with an uncomplicated infection, a shorter 5-day course is now the standard. Oh, you are going to love this. This is a fantastic little clinical pearl for dealing with that classic amox/clav diarrhea. To keep the gut happy, a prescriber can actually write two separate scripts, one for standard amoxicillin and one for a 7-to-1 ratio product. This way, you get the high dose of amoxicillin you need, but you keep the clavulinate, which is what causes all the tummy trouble, to a minimum. Seriously, this can be a game changer for finishing the full course. And let's not stop there. We can get ahead of some other common problems too. That awful bitter taste of cefuroxime or clindamycin, tell parents to grab some chocolate pudding or applesauce and mix it in. And don't forget about probiotics. The evidence is pretty good that they can help prevent antibiotic-associated diarrhea, and they only need to treat 9 kids to prevent 1 case. That's pretty good. Please, please, please do not forget this one. It's maybe the most important counseling point of all: pain relief. The antibiotic is going to take a day or two to really kick in, but that ear pain is happening now. Making sure the child is comfortable with acetaminophen or ibuprofen is absolutely key. It helps them sleep, it helps them feel better, and it's what makes that whole watchful waiting strategy even possible. So at the end of the day, it really comes down to this. Our role is so much more than just putting a label on a bottle. By giving this practical advice, we empower parents, we make sure treatments are actually effective, and we become frontline defenders of good antimicrobial stewardship. Every single one of these consultations is a chance to make a real difference.